This program is brought to you by Grand Valley State University.
I don't know, 2 decades really makes me sound so old. Your timing is impeccable, except for those of us who are doing a lot of these presentations, because I really have a lovely presentation about the implications of the Senate healthcare reform bill on Michigan on my flash drive. Unfortunately, it's probably why they call it a flash drive, because it is no longer relevant in today's environment. So I have a different presentation for you. However, if any of you want to know what would have happened in Michigan had the Senate bill passed, I'm happy to share that with you as well. It is an exciting time in healthcare reform, and because we are in this state of somewhat of uncertainty about what will happen. You know, I heard Nancy Pelosi talking this morning while I was driving over here about we're going to parachute in our healthcare reforms if we have to, and it's going to happen. Then I hear the Senate saying, no rush. We're not going to do anything right now. We're going to focus on jobs for the moment. But before the end of the year, we'll do something. So I think we are in a state where we really don't know what's going to happen on health reform. And I'll talk a little bit at the end about some of the challenges with some of the ideas that are being thrown out this week about where to go from here. Because I think there's some real difficulties with the ideas of breaking up the bill and things like that. And I'll talk a little bit about that. But what I thought I would do, since we are really unclear about whether, in fact, we'll have any major health reform in this country right now, is step back for a minute and talk with you this morning about why we really need healthcare reform and also why it is so hard to get it done. And I'm going to do it with Michigan as our focus because I think we are very much a microcosm of what we see in the rest of the country. And I'll talk nationally as well. But this is an issue that I think if you've been following healthcare, you know presidents have been trying or talking about trying to reform the healthcare system for a century. And with the exception of Johnson and Medicare and Medicaid, every major effort at healthcare reform has failed. And there are good reasons why that's happened, and we're leaving an open question mark on whether Obama will be in the failed category or the Johnson category. We'll have to wait for that answer. But there are very good reasons why it's been very difficult to do this, and perhaps even more important reasons why it's important to do it. And I want to illustrate both as I go through my talk today. And so what I thought I would do is really give you a picture of what at least healthcare looks like in Michigan today. And again, I'm going to talk as I go through what the issues are and what the challenges are as well. So first, and I think very important for us to understand, because it is at the nub of why it is so hard to change the healthcare system. And I think it's something that even in Michigan we forget. Healthcare is our #1 employer in our state today. You know, we have so much of our auto mindset, even with the downsizing in the auto industry, that I think that it's very surprising for people to know that healthcare is the largest employer in the state of Michigan, actually has been for quite some time. And it is the one employer that even with this economic challenge that we're facing is growing. This is true, of course, nationally. Healthcare nationally is 1/6 of the U.S. economy. And that in and of itself should tell you that changing anything about healthcare is going to be enormously difficult. There are a lot of interest groups behind these numbers. And every time we talk about the issue of healthcare cost and our need to restrain healthcare cost, well, that affects employment as well, because it's a very labor-intensive industry. So when we talk about wanting to grow jobs, wanting to grow our economy, healthcare is the only one that's growing. We talk about wanting to restrain cost, that affects industry, people, and it becomes a major challenge. So I just want you to keep that in mind as we go through the rest of the presentation, our #1 employer in the state of Michigan. Now, Of course, we started the discussion about healthcare reform nationally because of the issue of the uninsured, and that sort of got lost a little bit in some of the rhetoric and the dialogue. But we do, and I think you know, have about 47 million people in this country who are uninsured. In Michigan, it's about 1 million people who are uninsured. Michigan has a lower percentage of people who are uninsured than the rest of the country. We traditionally have had a lower rate of uninsurance than the rest of the country because, in fact, we have been a state with a long legacy of labor unions who've bargained for health insurance and set the pattern for many other employers, whether they were organized by labor unions or not. So we've always had a higher percentage of people with private coverage in Michigan than we see nationally, and we do a little bit better on this issue of uninsurance. But still, there are 1 million people uninsured in our state, 47 million uninsured nationally, and that is a very significant issue that healthcare reform was designed to address. And of course, not only do we see these numbers of people who are uninsured today at the current levels, but also we increasingly see businesses who are dropping coverage either entirely or in part, and there are folks on the panel who I know will speak to this because they deal with people who are losing coverage every day. In our state and nationally, more people are leaving large employers. Traditionally, virtually 100% of large employers offer health insurance coverage of some form, at least to active employees. It's a separate issue if you're retired. Small employers, most of them, or many of them, do not offer health insurance coverage. And so as we've lost employment in our state from large businesses, more and more people are going into small employers and losing coverage in that way. So this even, to some degree, understates the issue for our state. And as we look at data for this year and next, I think we're going to see an even bigger percentage of our population who are uninsured. Now, the issue, as you've heard nationally, is not just about coverage. Coverage is very important, but tied to coverage and tied to the issue of people's concerns about healthcare and why in the campaign it showed up as a top issue for many people, is the issue of cost. And this is showing you the average premium costs for people in Michigan. We're on a family basis somewhat lower than the U.S. average. What this doesn't show, and what's very important to also understand, is that people are picking up an increasing share of this premium cost. So for family coverage, people are now paying about a quarter of the premium cost if it's provided by an employer. For individuals, people are paying about a half of this premium cost that you see here. And of course, then you look on that earlier slide at the slice of the pie of people who have individual coverage. They buy it themselves. They pay the entire cost of the coverage themselves. And that's obviously something that's really critical because many people are finding it increasingly difficult to afford their share of the premiums and increasingly difficult to afford the copays and the deductibles that they have to face. And I expect many of you in this audience, if you have private coverage, you've experienced that increase in copays and deductibles yourselves and the increase in the share of the premium you're paying. And it is causing people to have difficulty getting access to health care. We know that from data that we and others have looked at in terms of challenges people are facing. So it's not just an issue about coverage, about whether you have an insurance card in your pocket, although that's important, but it's also about, even if you have that insurance card, can you afford to get the care that you need? And more people are saying that they can't. And it is why actually, when President Obama framed the healthcare discussions, he framed it as an issue around cost first and foremost, because the issue of cost and coverage are really tied together. Michigan has historically had lower rate of increase in healthcare costs than the U.S. average. Again, a fact that's little known in our state or nationally, but true. But even so, you can see on this chart that healthcare spending has been increasing, and what we didn't put on here was relative to any measure of inflation, any measure of growth in our gross domestic product. Whatever measure you want to look at, healthcare costs have been increasing at a much faster rate, and therefore consuming more and more more of any individual's income. And of course, one of the things that's little understood when people talk about employer-provided health insurance is that it's really the employees who pay for that health insurance. It's a compensation issue. It's a trade of wages for benefits, and those costs come out of the pockets of employees. And so it's as critical an issue for workers because wages have been depressed as a result of this rise in healthcare costs. And so that's why cost, again, is a very critical issue to prosperity. It's why people frame this issue, why the president frames this issue, and many advocates frame this issue as an economic issue. It is an economic issue, and dealing with the cost is very critical. Dealing with a cost is very complex, and I want to spend a good chunk of this talk on the cost issue to help you understand why it's so complex and why, again, the changes in healthcare reform are so difficult to actually accomplish. So this is the top 5 diagnoses by discharge cost here nationally and in Michigan. They're very similar. This is the Michigan list here. If you go to our website, and you'll see that up at the end, you can get much more detail on the burden of disease in Michigan compared to the U.S. But, you can see on here, and we put the U.S. figure here, that the number one cost burden of disease is coronary artery disease of some form and procedures related to coronary artery disease. I'm going to talk more about that as I go when we look at a number of factors here, but it's very important to understand that a lot of what happens with regard to coronary artery disease is preventable. And there are also a lot of choices in the type of care that people get for those types of diseases. So just important, I think, to keep in mind what's driving our healthcare spending. Now, you may have heard, if you've been following the healthcare reform debate, a lot of talk about work that's been done by folks at Dartmouth about the issue of variation in spending across the country. And this is an issue that policymakers lately have been focusing on a lot. It's interesting because this research has been out there for more than 30 years now, but the attention to it has really escalated in this round of discussion about healthcare reform. This is simply a map to show you overall healthcare spending by region in our country. And if you read, there was a great article in the New Yorker in May, I believe it was, of 2009 about McAllen, Texas. Atul Gawande, who is just a lovely writer, had gone to McAllen, Texas. He knew this data. He went to McAllen, Texas to try and understand why McAllen, Texas was basically number one in healthcare spending. What was it about that community that made their spending so much higher when you adjusted for age, sex, race, things like that? So this is a Medicare population, you're looking at the same kinds of populations, and people have been trying to understand, why is Miami, Florida one of the highest spending regions in our country? McAllen, Texas. Why is Honolulu and Minneapolis and Portland, Oregon? Why are they such low spending regions in the country? It's not driven principally probably by differences in disease state, because we're matching disease states, or in severity of the patients. So what is it that drives that variation? And it's been a big part of the dialogue about healthcare reform and why we need it. People recognize it. I will tell you, and I'm going to show you a couple more slides on this topic in a minute, that it's also very difficult to figure out what to do about it. We don't have good explanations for why this variation occurs. We know when Atul went to McAllen, Texas, and he interviewed the providers, they were all surprised that they were so high. They just didn't know this, and he came up with some theories that had somewhat to do with the structure of healthcare, that had to do with some emphasis on for-profit healthcare, some investments in technology and things like that may have made a big difference in that community. But I think it's fair to say that those providers really didn't know how they stacked up relative to others, and it was something that was quite enlightening to them. Now, we'll have to look in a year to see whether or not they've changed their practice patterns based on this data, but it's something that is very important for us to understand. So let's look at Michigan, and you can see these are what's called hospital referral regions. HRR is a way of looking at healthcare based on communities where there is a tertiary referral center. And I don't have time to go into the whole methodology, but it's essentially some aggregation of communities here. So it's not just the city, but it's really where people are getting their care. And you can see on this chart, this is ranking high to lower cost in Michigan. And the numbers actually are the national rank. There are 310 or so HRRs in the country. And so low, you can see that Marquette is really quite low nationally on HRs, as is Grand Rapids, 199. And we've known in this state for a long time that Grand Rapids has a more conservative approach to medical care, and I'm going to show you some quality statistics, good care, but much more conservative that results in overall a lower healthcare spending than the national average, lower healthcare spending than many, many regions in our state with basically good outcomes. But if you look below the numbers, you see some different things. So this is back surgery. The red dot, this is called a turnip plot. Looks like a turnip, right? The red dot in the middle there is Michigan. These are states, and it's simply a plot. These are states by the use rate of procedures. And so on back surgery, Michigan's a little bit higher than the U.S. average overall. And if you look within our state, here's an area where Grand Rapids is actually fairly high. Now, why is this? Why do people in Grand Rapids, Muskegon, have a higher rate of back surgery than in Ann Arbor? Is it because we work out more in Ann Arbor and, we keep our backs strong? I don't think so. Is it because there's some other patient characteristics about those of us in Ann Arbor that are different from Muskegon, Grand Rapids? I don't think so. So what is it? And we can talk in the Q&A about some of the theories behind what drives these numbers, but it's something that has gotten a major focus in this healthcare reform discussion, because we can't explain these variations based upon patient health condition. And if you could reduce these variations to the lower end, because most of the data that we have says that health status and health outcomes are very good with lower spending, and that we're really not getting a lot for that higher spending. And so again, if you look at overall statistics of health status in Minnesota, in Minneapolis, they're very good. And it's why the Mayo Clinic gets held out often as a one that people like to point to as really having a great model. And so if we could reduce our spending to those lower spending communities, we would have free up tremendous amount of money in the system. More than enough to cover the uninsured with very generous benefits, more than enough to pay for the subsidies that would have been included in the Senate reform bill, and more than enough to help reduce the deficit. There's tremendous money here. It's how you get there that's very difficult. Let's look at one other procedure here. This is angioplasty. Michigan is the red dot on this turnip plot. Michigan is very high on use of angioplasties in the country. And here you see a very different picture. Here you see Grand Rapids actually quite low on use of angioplasty. And you see St. Joe's, Michigan, as the highest in the state on angioplasty. Again, and we can talk about this as to why these can be and what to do about them, but it's a very significant issue. The variation is just not cleanly explained by patient characteristics. And so there's something in the way care is being delivered that we all believe, I think everybody uniformly on the health policy side believes we can intervene. The result, and make a difference on savings, the result of this data, or most health researchers putting all this data together, this is where you come up with the numbers that you may have heard, that 30% of healthcare spending is, some people say wasted, some people say not adding value, some people say discretionary, depends on your bias and what your politics are at the moment, which words you use. But there is certainly, I think, increasing consensus, if anything, in the health policy world that 30% of spending is not adding the kind of value that you would expect for that kind of investment. And so it's critically important that we change that picture. Now, I told you about Quality, what I didn't bring today, and I could have shown you data, but I'm sure you've heard this before about what we're getting for all that spending is not producing overall improvements in things like infant mortality, life expectancy, and the like. I think but just in case not, the U.S. compared to other countries on all of those measures does not perform particularly well. In fact, we rank 36th or 37th in the world, just right next to Cuba, in just about all of those measures of health status. And so again, there's this real question of what we're getting for what we're spending. But quality overall, the U.S. average, at least in looking at hospital quality on these measures, and they're not perfect measures, looks pretty good. We have some opportunities for improvement. Just to give you a sense of how Grand Rapids hospitals perform on these particular measures, all the Grand Rapids hospitals perform at least at the U.S. average, if not better, in most cases. And so the quality is generally good. We know we have opportunities there, but it has been a lot of the discussion has been about quality in healthcare, and yet I think if you ask most consumers, they have this view that quality in the U.S. is very good. And part of the challenge is convincing people that we need to change, because I think for most people, they feel like what they get from their doctor, from their hospital, is good quality medical care. So now let's talk just a little bit about health status in Michigan, because I think it's really important to understand the health status issues as well, because they also feed into that whole picture of what we see in terms of healthcare spending. So this is the prevalence of obesity. Unfortunately, Michigan is the higher number here, the top number compared to the U.S. I would expect, because press coverage has been pretty significant on this issue, that you're aware that the rate of obesity in this country, and frankly in the world, is increasing and has been, as you can see here, steadily increasing. And unfortunately, Michigan's rates of obesity are higher than the U.S. average. Remember, I showed you earlier the cardiovascular disease is the number one spending disease burden nationally and in Michigan, and we know that obesity is directly connected to that. And there's data out there now that says that the cost or the contribution to healthcare spending of obesity is more than the contribution of smoking, which is a real change from the trends that we've seen. I'm going to show you the smoking trends in a minute. But this is a huge issue, so to speak, and it's a very important issue and also a very difficult issue, because, frankly, we don't know how to change this picture very well. We've done lots of research to look at what the research is about what programs actually work to reduce obesity, and there is not good data to show any programs work on a sustained basis really well. It's very challenging. The only one that we really have data to show that it works on a sustained basis very well is bariatric surgery. Bariatric surgery is the stomach stapling surgery, and it's become an increasingly safe procedure, and it is a procedure that does work to reduce obesity. And so this is an issue that we are going to have to, as a country, continue to struggle with, because there's no question it is feeding into our healthcare spending nationally. And again, I didn't put the international rates of obesity. They're going up, but we are still higher than the national rates overall for most countries. Not Tonga. If any of you have been to Tonga, I can tell you their rates are much higher than ours. But it is a big issue in this country. Now here, I told you that obesity is an issue that's growing, and one that is causing more spending now than smoking. And here are the data on the smoking trends. So again, Michigan is still higher than the U.S. average, and maybe after the ban the legislature passed in the state that goes into effect in May, we'll see the picture change. We're excited. I think we're the 37th or 38th state now to join with a smoking ban. But the rates have been coming down for a variety of reasons. What we know that works on smoking is when you raise the tax on cigarette packs. So we know there how to really affect these rates, and that's a large reason why you see these rates having come down. Unfortunately, we've just been looking at the data on youth smoking, and we'll be publishing some of that data in the near term, and those statistics are not very good. We're very concerned. 20% of the youth in grades 9 through 12 are smokers, are smoking at least to some degree, and that's obviously of great concern because it's very important in terms of the impact on health status and the impact on healthcare use as well. So putting those two together, the issue of obesity and the issue of smoking, you can see that the issue of cardiovascular deaths per 100,000 population is very significant nationally and even more significant in Michigan. So tying it back to what we're spending for healthcare, cardiovascular number one in our spending nationally, and in Michigan looking at health status issues, looking at the health behavior issues of obesity, smoking, and the like. Putting those together, we know that this is a critical issue, and again, a very difficult issue to change. Okay, so what are the reform implications for Michigan? And let me just wrap up in a couple minutes before I ask the panel to come up here so we can have this discussion collectively. I just want to emphasize a couple of points about why it is so hard to change this picture and the federal bill. What I just showed you in terms of cost, in terms of health status, in terms of practice patterns of practitioners, first of all, they're all tied together. Can't just affect one very well and have all of the others affected. And second, when you tend to talk to different audiences, they tend to say it's the other group's issue. So you tend to talk to consumers, and they tend to say, well, it's the high cost of insurance companies, and it's the doctors doing too many procedures or whatever. You talk to doctor groups, and Dennis can speak to this, and they'll say it is patient behavior, and too many people are eating too much or whatever. And it's very, very hard to get the groups in the room and to all say everybody has a stake in this, and everybody has to be part of this solution. It's not just Republicans and Democrats. It's every component of the healthcare system has to be part of this solution. Again, 1/6 of the economy, but everyone uses healthcare, participates in healthcare in some way, and has to be in this game. And so the reason you had a 2,000-page bill in the Senate bill is because that bill was trying to affect every component of healthcare. It had incentives in there for consumers to engage in healthy lifestyles. It required preventive coverage in certain areas to have no copays for Medicare population and for others. It had rules on insurance companies. It had various pilot programs in there to test new approaches to reduce variation in healthcare and reduce spending by paying providers differently. It covered everything. All aspects of the healthcare system were reflected in that bill. And it made it very contentious with just about every interest group. You had actually an amazing consensus around the need for reform, and you saw deals being cut. Well, that is how legislation gets done. To legislate, you've got to negotiate. And so the pharmaceutical manufacturers came forward with what they would put on the table in return for supporting legislation. The hospitals did the same. The physicians did the same. And so there were lots of deals in there that gave something, but got something in return. And what you heard more about in the press was what the gots were. And that made people generally pretty uncomfortable. Because there were a lot of them. And there were a lot of them because the bill was so big, because the health care issue is so complex. And this bill was trying to do everything at once. So what's the issue? And I'll conclude on this. What is the issue with splitting apart the bill? There's a lot of talk right now about, well, we'll just take it in pieces, and we'll do insurance reform first, and then we'll do other pieces. And the problem with that is the bill was complex for a reason, not just because it was trying to address everything together, and because everything's so big, but because these things are truly tied together. So let's just take insurance reform for a minute. If we look at the issue of a very simple, everybody can agree that nobody should be excluded from coverage because they were sick before. It's what's called a pre-existing condition, right? We all agree conceptually with that. The insurance companies even agree with that. But what the insurance companies said with legitimacy is that, okay, we agree not to exclude people based on their prior conditions, but only on one condition, and that's that everybody's in the pool. And everybody has to be in the pool because that's the principle of insurance. Insurance is all about pooling the risk and sharing the cost. And you can't just have sick people in the pool because then the cost goes way up. You have to have healthy people in the pool as well. And so unless you require that everybody be in the pool, and that's what the mandate was all about, unless you require that everybody be in the pool, then you only have sick people getting insurance, unless you give it to everybody for free, which, that's not going to happen. We're not going to be a single payer, and that would be a simpler solution, but that's not going to happen in this country. That wouldn't be free either. It would be in our tax system. So, there's a lot of complexity with that. So unless everybody's in the pool some other way, you get the mandate. And that's been not something very popular. And then, because that brings with it a whole set of other issues, subsidies, and how do you enforce it, and what happens if people don't. That makes it really complicated, right? But you can't just prohibit pre-existing conditions without getting this problem, and it's actually an issue and discussion in our state right now, because Blue Cross is saying that because they can't exclude people based on health status, and they're saying the cost of their pool is going way up, and there's some data to support that, et cetera. So it's a big issue. You can't just take that one piece. So you end up with, well, we can improve quality. Everybody can agree on that. That's kind of independent. I can tell you there has been a patient bill of rights proposed in Congress for over 10 years. It really isn't very radical. It really won't do much, and it certainly won't give more people coverage. They can't agree on that because every interest group has a piece of it that they don't like. So if you really want to expand coverage, which everybody says they do, everybody on both sides, and if you really want to deal with cost, you end up with a very complicated bill. There is no way around it. And so, well, we're going to have to see. This question mark will only get bigger over time.
The preceding program is copyrighted by Grand Valley State University. Visit us at gvsu.edu.